Adoptive T-cell therapy has been used already with success in melanoma. In this trial, we are using TIL, which are tumor-infiltrating lymphocytes, directly extracted from the tumor of the patient, to hopefully successfully treat metastatic non-small cell lung cancer, which has no associated mutation, no driver mutations, who have progressed, in patients who have progressed after first-line chemotherapy plus immunotherapy plus or minus bevacizumab. Our background, so the background of this approach has been that we've seen good results in melanoma cancer, and now we want to apply it in non-small cell lung cancer. So the patients who will undergo, who will be enrolled into the clinical trial will have to provide a tumor sample of about 1.5 centimeter. Basically, this tumor sample will be shipped to a central manufacturing facility. So the suppressive tumor microenvironment, the tumor infiltrating lymphocytes will be extracted and reinvigorated and expanded to then be reinjected in the patient. So the product, which is called LN-145 manufacturing, and so the product will be manufactured in about a period of time that will go up to about 3 weeks. So between 2 to 3 weeks will take. So this is important because it's not as long as it needs to be in other trials, T-cell therapy trials. And in addition to that, the advantage is that patients do not have to be profiled for HLA. So the trial is currently approved. So the trial is Iovance LAN-202, and the product, I said, is LN-145. It is a phase 2 multicenter study trial that is open currently at City of Hope. So we are currently looking for subjects to be enrolled in this trial. So please, if you are in the area or if you want to refer a patient for this trial, just contact me and I'll make sure that the patient will be seen promptly. So we're currently in the active phase of the trial. So the idea is to enroll about 95 patients, which will be divided in 3 different cohorts. So the cohort 1 is in patients who have PD-L1 tumor proportion score less than 1%. Prior to checkpoint inhibitor. The cohort 2 is with patients with PD-L1 1% or higher. And then the cohort 3 will be basically PD-L1 less than 1%, unable to safely undergo surgical tissue procurement. And then there is a cohort 4 that will allow retreatment of patients who had previously responded and then progress after a certain amount of time. So the first 3 cohorts will be open for enrollment, and the inclusion criteria are mainly patients who are progressing after first-line standard of care therapy with chemotherapy, immunotherapy, so checkpoint inhibitor plus or minus bevacizumab, metastatic non-small cell lung cancer without actionable driver mutations. And also they will need to have an ECOG performance status 0 to 1, measurable disease by RECIST 1.1, and a left ventricular ejection fraction higher than 45%, and FEV1 higher than 50%. So basically, once we have enrolled the patients, so we'll look at the data, the interim data, and will decide how to proceed, with the trial. But as of now, we are hopeful to at least start the accrual of this trial. So T-cell therapy is an important opportunity for patients, especially the ones who do not have driver mutations and with metastatic non-small cell lung cancer and progressed after checkpoint inhibitor therapy and chemotherapy, because unfortunately these patients have a very limited number of opportunities. So I think it's very important to understand that for this kind of trial, we're selecting patients right after first-line therapy. So if you have any patients you're thinking might benefit from this trial, please call me. My email is emassarelli, MASSARELLI @coh.org. Thank you.